Hi, good evening, everyone. Me, myself, I'm Dr. Viswa Theja, Consultant Emergency Medicine working at Yashoda Hospital, Hitec City. I welcome you all to the weekly webinars we conduct as a Department of Emergency Medicine at Yashoda Hospitals. Today, we are going to discuss a important topic on oncological emergency, febrile neutropenia. Being an emergency physician and emergency doctor, we should have a basic knowledge about different emergencies cancer patients present to our ER. Usually, these patients are immunocompromised due to their primary illness or due to various therapies they undergo during their course of treatment. Also, some specific conditions like febrile neutropenia and tumor lysis syndrome are also common in cancer patients. To discuss more regarding the topic, I have here with me today Dr. Shikhar Kumar. He's one of our leading medical oncologists and he's a dear friend of our team. And we had a really good discussions when he comes to emergency to see his patients. And it's really good to have your presentation today, sir. You can go ahead.
Thank you, Dr. Vishwa, for the kind introduction. With that, let's start the proceedings. So as Dr. Vishwa said, febrile neutropenia is a very important complication that most of us as oncologists have to face on a daily basis, and something which usually the first point of contact for someone who suffers from febrile neutropenia is always the emergency physician. So it is very important and a very relevant topic for this particular audience as well. I will be covering some of the basic things and the basic issues that we need to consider when we discuss febrile neutropenia as a whole. I'll talk about the risk factors which predisposes one to develop febrile neutropenia. And most importantly, what is the initial assessment and the evaluation that needs to be done in either the emergency or in the OPD if the patient lands up in the OPD by some chance. And then how do we risk stratify patients and decide what kind of management needs to be done for these patients? How do we manage the low risk group? How do we manage the high risk group? We'll talk a little bit about antibiotic policies. What is the so-called escalation approach? What is the de-escalation approach? And how do we subsequently reassess the patient? And then finally, we'll look at the take-home points. I have deliberately not included subtopics like management of fungal infections, which also is a consideration when you deal patients who have prolonged febrile neutropenias. That is something which is currently out of the scope of today's topic, as this is mainly geared towards the initial assessment and decision making, which is more so relevant for emergency physicians. To define febrile neutropenia, basically this means that any person who has fever and has neutropenia with a neutrophil count of less than 500 per microliter, because this fever in someone who is neutropenic could signal a potentially life-threatening infection, and this should initiate prompt empirical therapy with broad spectrum antibiotics. This is what it was defined long back in an important study in 1966. And we know that febrile neutropenia is one of the most frequent and serious complications of cancer chemotherapy. It not only contributes to a lot of morbidity, it utilizes a lot of healthcare resources. It ends up delaying your subsequent chemotherapy cycles. Patient has to undergo dose reduction, which ultimately compromises the efficacy. But it can also contribute to cancer-related mortality as well. However, as time has evolved, our chemotherapy regimens have become more and more safe, and we have begun using more and more growth factor support. That is, primary prophylaxis with growth factors has increased a lot, to the point where I would say that it's even overused in current practice, which is why the incidence of febrile neutropenia has decreased, but this will never be completely eliminated. So to look at the technical definition, any patient who comes to the ER with an oral temperature of 101 or above, which is sustained for more than 1 hour, and a concurrent CBC report shows that the patient has neutropenia, that is an ANC count of less than 1000, or a severe neutropenia, what is known as a grade 4 neutropenia, less than 500. would classify as a patient having febrile neutropenia. Just last night, we had a patient who landed up in the emergency post chemo with a high grade fever of 101. We did a CBC, and the moment the CBC report came out as the TLC being 12,000, the patient was asked to go back home and not to do any further unnecessary investigations, because this would not categorize as febrile neutropenia. What are the risk factors that predisposes one to develop a febrile neutropenia? We can categorize them into patient-related factors. What is the underlying malignancy, which can itself be a factor, and what is the treatment? Looking at the patient-related factors, the risk of febrile neutropenia is definitely more in elderly patients. That is, in patients who have ages more than 65 years. If patients have a slightly weaker performance status with a low serum albumin level, because the drugs, these chemotherapy drugs are usually bound to the serum albumin, many of them. So if the albumin levels are low, the unbound drug levels in the plasma are more, and thus they have more toxicities. Patients who have multiple comorbidities, diabetes, hypertension, CKD, asthma, these are patients who are likely to land up in more complications because their physiological reserve is low. So they end up developing more and more high-risk febrile neutropenias with hypotension, needing vasopressor support, etc. If you look at the underlying malignancies, which can predispose to febrile neutropenia, virtually every single patient who has a hematolymphoid malignancy in the form of a high-grade lymphoma or a leukemia will have febrile neutropenia at some point or the other in the course of their treatment. Next comes soft tissue sarcomas, because the chemotherapy regimens used to treat these sarcomas are very intensive, because these are chemo-resistant tumors. So we really have to pump in high doses of chemotherapy, which can cause febrile neutropenia. And then come the other cancers like myelomas, germ cell tumors, and others. In the same way, this graph represents that with increasing stage of the disease, patients who have stage 4 disease have a slightly higher propensity to develop febrile neutropenia, and patients who are having acute leukemia, if they are not in remission, that is, if their bone marrow is still full of the cancer blasts, they are more at a risk for developing febrile neutropenia. These are the treatment-related factors which show that if you give chemotherapy at such high doses, you will have high risk of developing febrile neutropenia. Let's not go into this, and let's come into the interesting part. That is, how do we assess these patients and approach them when they come with this complication? The most important thing is a complete history and a physical examination. In the history, try to identify a focus, see if the patient has any other localizing symptoms, and then perform a quick and a thorough systemic examination. And in this, it's always important to start from the top, look at the oral cavity, see if the patient has any mucositis, which can be a harbinger of occult gram-positive infection. We'll come back to the relevance of mucositis once we come to the antibiotic approach. See if the patient has any sinus tenderness. Look under the axilla, it might be hidden. You might have a infection source in the axilla in some patients. Some of my patients, they have a PICC line inserted, and I'm sure that we will be seeing more and more patients landing up with catheter-related bloodstream infections, because the number of patients with PICC lines will increase. And always look at the PICC site if it is there. See if there's any tenderness, any inflammation, any post-PICC line flushing-related history of chills. Okay, all this can indicate that patient has a catheter-related bloodstream sepsis. Always look at the perianal region. Does the patient have any tenderness while palpating in the perianal region, which can be an indicator of, that can be a focus of infection. Look at the groin. And after looking at these sites, you get a rough idea as to the overall burden of the symptoms and the disease in the patient. Once this is done, once you have examined the patient completely and you have taken a good history, immediately send off the complete blood count with the renal liver function tests. The serum lactate can be sent as a part of the venous blood gas. And the most important thing is, as I'm sure you all know, it is taking the blood culture. Once you get the hemogram report and the patient is neutropenic, it's very important to take a blood culture. If the patient does not have a central line, a peripheral culture would suffice. 2 peripheral cultures. if the patient has a central line, like a chemo port or a PICC line, always take a culture from the chemo port or PICC line. And in this regard, I would urge all emergency physicians to train their nurses under the onco nurses who are already working in their establishments to learn how to draw blood samples from the PICC line or from the chemo port. Because if the patient lands up in the middle of the night, we cannot delay the testing of the samples from the central venous access devices until the next day when the onco nurses come in the routine duty. If there are any other cultures as per the patient's symptoms, a sputum culture or a urine culture, send those also for testing. If the patient has the symptoms of a lower respiratory tract infection, do a chest imaging. And in this regard, I would say we should now start looking more and more away from chest X-rays and start doing non-contrast CT scans of the chest more often, especially in cancer patients who are receiving chemotherapy. You can do a throat swab if it is indicated. So this all assessment should happen within the first 10 to 15 minutes of the patient coming up in the emergency. And once this is done, the first dose of the antibiotic should be administered to the patient within 1 hour. This is of utmost importance because multiple studies have indicated that the more you delay the first antibiotic dose, the higher is the risk of mortality because of febrile neutropenia. Just to define, about a blood culture, what is a blood culture? You should send at least 2 sets of blood cultures. Each set consists of 1 venipuncture or a catheter access draw of at least 20 ml of blood, which should be divided equally into aerobic and anaerobic blood culture bottle. Nowadays, this is something which I have been observing a lot. We are getting a lot of gram-positive contaminants in our peripheral blood cultures. So the nursing staff should be sensitized and they should be trained about the proper techniques of drawing a blood culture from the peripheral venous line and follow the strict aseptic precautions that needs to be done when drawing a blood culture. So we know that we send, more than 2 or 3 cultures repeatedly because the more cultures you send, the more is the probability of picking up a bloodstream pathogen. So as of now, sending 2 sets of blood cultures is the current standard of care for any patient who lands up with febrile neutropenia. Once all this is done, and then you have to decide about the next step, that is the antibiotic policy that you're going to follow. We have to risk stratify these patients and decide how to manage them further. So in this regard, there have been some risk stratification models. We will not go into it in much detail. The most important classification is known as the MASCC classification system, which contains these parameters. I would not say that this is very widely used in clinical practice, but it is worthwhile to know that this exists. And this gives you some idea as to how these patients are overall approached, how we approach these patients and how we make our decisions. So basically you get a score based on the patient's burden of symptoms, whether the patient has hypotension or not, whether the patient has COPD, whether the patient has a solid tumor or a hematological malignancy, if the patient is dehydrated or not, was the patient an outpatient when he came up with fever, and the patient's age. Based on this, you calculate a score. And if the patient's score is 21 or more, this indicates that the patient has a low risk febrile neutropenia. Any score less than this indicates that the patient has a high risk febrile neutropenia. So someone who has a very high severe symptoms, patient has hypotension, patient is dehydrated, automatically would fall into a high risk febrile neutropenia. There are some shortcomings of this classification in the form of this burden of symptoms is quite a subjective issue, and other comorbidities apart from COPD are not taken into account in this classification model. And the duration and the anticipated depth of neutropenia, which is a very important parameter, also is not taken into this model. Anyhow, based on the MASCC model and some other risk factors, we can classify patients into low risk and high risk. Low risk are patients who have not received a very intensive chemo. You expect them to have a brief neutropenia, what is called as a paper neutropenia. who don't have any comorbidities, they have come walking into the ER, they don't have hypertension, they are clinically very stable. Okay, they have just come because of the blood test that they have done on a particular day has shown that neutrophil count is a little low. You don't need to be very worried about these patients. These patients can be treated with oral antibiotics. But patients who are looking sick, those who have come with mucositis, those who have new infiltrates in the CT scan, in the lung infiltrates, those who have hypotension, any patient who has a central venous access device, any patient who has a profound neutropenia that is defined by a neutrophil count of less than 100, these are the patients who would need IV antibiotics and inpatient admission immediately. And this is the same stratification based on a different risk model, but the basic concept is the same. So patients who are low risk can be treated with the oral antibiotics. There are different oral antibiotics. There is no one single standard of care. You can treat these patients with amoxicillin clavulanate, or you can treat them with oral ferropenum, which is also orally available cephalosporin. There are different drugs that we use, but most patients that we would be seeing routinely would be falling into the high risk febrile neutropenia. And for these patients, we have to decide about the antibiotic of choice. So what is the empirical antibiotic that we choose for high risk febrile neutropenia patients? What is the rationale for empirical antibiotics? Why do we start antibiotics even before we get the blood culture reports? All this is because to prevent morbidity and to prevent mortality, because we know that these patients have a high risk of having a bacterial sepsis, and based on several studies, landmark studies that were done long ago, patients who were having neutropenia, when they waited until the blood culture reports to start the antibiotics, these patients had a very high mortality rate. Look at that, 50% mortality rate. This dropped drastically in patients who were treated empirically. The moment the fever started, I can see that there is a sharp reduction in mortality rates when you start the antibiotics, when the patient has only fever and you don't have the blood culture report yet in your hand. So empirical antibiotics is the current standard of care for these patients. And the basic principle of these empirical antibiotics is that these should cover gram-negative organisms and it should cover pseudomonas. Okay. The problem is that you deal not only with gram-negative infections, but you also deal with gram-positive infections. Sometimes you deal with polymicrobial infections. And your blood culture reports are not always positive. We know that blood cultures have a poor sensitivity. Only around 20 to 30% cases you actually get positive blood culture reports, right? And in the Indian setting, you would see that our burden of disease, you would see gram-negative bacteremia more than gram-positive, and our gram-negative strains tend to be more virulent with more drug resistance. This was another study from Tata Memorial Hospital where I was trained, where we could see that blood cultures were positive in only 17.7% of patients. In the rest, it was all negative. And if you look at the TMH data, you would see that in most of these patients who have positive cultures, the leading organism is Pseudomonas, with around 30 to 40% of patients having Pseudomonas, followed by E. coli and Acinetobacter and Klebsiella. So gram-negative organisms, they totally dominate the culture spectrum. So that is why the first line agents are decided based on this fact that we know that gram-negative bacteria they dominate the sepsis patterns in our setup. And that is why we choose these antibiotic agents like third generation cephalosporins with ceftriaxone, sulbactam, ceftazidime, cefepime, or we choose carbapenems like imipenem, meropenem, or piperacillin tazobactam, because these are all agents which have demonstrated anti-pseudomonal activity. How do we choose which one is the correct agent? There have been several trials that have been conducted. They have compared meropenem versus ceftazidime. They have compared imipenem, cefepime. They have compared triptaz with cefepime. But more or less, all the first line agents are equally efficacious. And the IDSA guidelines, they usually recommend empirically to start with monotherapy, to start with one agent which has good anti-pseudomonal coverage. Combination therapy with both your beta-lactams or carbapenem plus aminoglycoside is recommended only in select situations. There have been several trials which have compared monotherapy versus monotherapy plus aminoglycoside in febrile neutropenia patients. This was a large meta-analysis which by and large showed that the outcomes were not superior if you combine beta-lactam with aminoglycosides. Monotherapy was favored over combination therapy, and the mortality rates were again favoring patients more towards monotherapy, and your adverse events were more when you had too many antibiotics going in. That is, combination therapy was having a little bit more adverse events. But in some situations, when the patient has a high suspicion of having a pseudomonas infection, say someone who has had pseudomonas infection in the past, someone who has pneumonia, someone who presents with septic shock, in these cases, you don't want to take a chance and you treat the patient with combination therapy with both aminoglycoside and your beta-lactams or carbapenems. Okay. So based on our this is the data from TMH. I strongly urge our physicians to generate our own data, to look at our own antibiograms. Now we have an infectious disease consultant who has joined us. We have started blood cultures in our own unit. After a few months, we should look at our own blood culture data and look at the resistance patterns, see how many MDR bugs we are growing in our cultures, and decide on our antibiotic policy. And whether to use a monotherapy, whether to use a combination therapy, we can get this answer only once we look at our own resistance patterns. So this is what is followed in TMH, and this is what I follow in my own practice as of now. Any patient of mine who comes with a febrile neutropenia and has a high risk disease, I start them on empirically cephalosporin sulbactam, which has good anti-pseudomonal coverage, along with aminoglycoside, that is injection amikacin. Someone who has a body weight of less than 50 kilograms, they are treated with cephalosporin sulbactam 2 grams IV BD, and amikacin, we all know it is 15 milligrams per kg body weight to be given once a day. When do we add gram-positive cover to this empirical regimen? These are the indications. Patients who have severe mucositis, grade 3, grade 4 mucositis, some chemotherapy regimens, they predispose more to mucositis than others. That is why I said it is very important to look at the patient, examine the oral cavity and see if the patient has mucositis or not. So patient who has severe mucositis, someone who has a skin soft tissue infection, you know there's a high risk of having a MRSA related infection. Someone who has a pneumonia, you do a CT chest, you see a consolidation. Someone who has, you're suspecting that the patient has a catheter related infection. Someone who is having hemodynamic instability, someone who is having hypotension, you need to push in a bolus of fluids just to stabilize the BP. And of course, someone who has a prior positive culture. In these all indications, you would add gram-positive cover. I think the drugs that I usually use in my practice is teicoplanin. Vancomycin also is another drug, but we have more experience and we are more comfortable with using teicoplanin. That is what I use and recommend in my patients. So these are the gram-positive drugs that we have. I think vancomycin, teicoplanin, these are the first line drugs of choice. And someone who has a vancomycin resistant bug growing in the cultures, these are the patients who would then be treated with second line gram-positive drugs like daptomycin or linezolid. So once you have treated your patients with the high risk, once they come under the high risk category and you have started them with empirical IV antibiotics, then you wait for the blood culture reports. And based on the blood culture reports, you reassess the antibiotics that you're using, whether it is the right antibiotic or not, whether you need to add an aminoglycoside or whether you need to switch from a beta-lactam to a carbapenem, or if someone who has a Clostridium difficile infection, you're suspecting someone who has abdominal symptoms, you add metronidazole, okay? And then you observe whether the patient is having defervescence or not. But we are dealing with more and more in our practice with CREs. We are dealing with multi-drug resistant Klebsiellas, multi-drug resistant Pseudomonas, highly virulent organisms, more and more MRSA. So with this approach, it's more and more important to develop an antibiotic stewardship program and to follow this policy of either escalation or de-escalation. And this is something which we would only know once we have looked at our own culture reports and we have formulated our own strategy. Basically, you have to look for when you decide about the antibiotics that you're going to use for your patient, you have to look at what prior blood cultures the patient has had in the past, whether the patient has been on broad spectrum antibiotics previously or not. For example, if the patient has undergone a long post-operative stay, patient required a lot of broad spectrum antibiotics which are mentioned in the patient's discharge summary, and then the patient has come for readmission with febrile neutropenia, you know that this patient has a high probability of being colonized with a multi-drug resistant bacteria. Someone who has had a indwelling catheter for a long time, either a central line or a Foley's catheter, and depending on the clinical presentation of the patient, how sick the patient is when he lands up in the ER. Based on this, you decide whether the patient needs an escalation approach or a de-escalation approach, as opposed to someone who has a very uncomplicated presentation, no prior history. If you look at the previous discharge summaries, there's no prior long admission, no broad spectrum antibiotic use. In your center, if you're having, say, no very low MDR rates, these are the patients who you treat with the escalation approach. So escalation approach, you treat with the patient with the drugs that we have discussed just now. You treat them with simple ceftazidime, plain ceftazidime, or piperacillin tazobactam, or cefoperazone sulbactam. But someone who has the risk factors, like I mentioned previously, with repeated admissions, previous positive cultures, or in your center, if you have analyzed your data and you see that you are having lots of MDR sepsis, these are the patients that you should treat with a de-escalation approach that start them directly with carbapenems or carbapenem plus colistin, meropenem plus colistin, wait for defervescence, and then de-escalate to your lower level antibiotics. So this is what this graph ultimately tells us. This is the same thing which I mentioned, that look at the patient's history. When the patient comes up in the ER, look at whether they have been admitted previously with febrile neutropenia or not. See what is the appropriate antibiotic that the patient needs and administer it immediately. Subsequently, of course, this part does not happen in the emergency. This happens in the ward when we are looking at the patient on a daily basis. We follow up the blood cultures. We look at the patient critically and see if the patient has defervescence, has had defervescence or not. Someone who has a hematological malignancy, we don't expect defervescence immediately. Usually it happens at a median time of 4 to 5 days after starting antibiotics, and if the patient's cultures are normal. Someone who has a low risk FN or someone who has a solid tumor, you would expect defervescence in roughly 48 hours. So this is what we do in the ward. Someone who has started on antibiotics, we look whether the patient's tachycardia has resolved, whether the hypotension is better. We look at the fever spikes, look for new symptoms, and then we follow up the blood cultures. We modify the antibiotics if necessary. Look at the adverse effects of the antibiotics that we are administering. If you're giving aminoglycosides like amikacin, you have to monitor the renal parameters closely, and you have to do appropriate imaging as indicated. Based on this, we change to the subsequent antibiotics if warranted. So like I said, someone who is on an escalating approach, suppose if the patient suddenly deteriorates, we examine the patient again, repeat cultures, we broaden the antibiotic coverage, look for other etiologies, fungal sepsis, fungal pneumonias, and etc. Someone who is stable, someone who is responding to the treatment, you continue the antibiotics until the neutrophil count recovers, and then you can stop the antibiotics. Someone who is on a de-escalation approach, you go directly all guns blazing with your carbapenems and colistin. If they still continue to deteriorate, you again do a thorough examination, try to find out the focus of the sepsis, and you treat accordingly. Someone who has stabilized, we continue the same antibiotics until the neutrophil count recovers. And someone who is taking a little bit longer to stabilize, someone who is now becoming a little bit stable, slowly and slowly, you can narrow the antibiotic policy, and you can discontinue your most toxic antibiotics first, like you can discontinue colistin, and then you can discontinue the gram-positive cover, then discontinue the aminoglycoside, and then you can even change the carbapenem to cephalosporin if indicated. How long do we give antibiotics? Until the neutrophil count recovers. That is very important. And beyond that, it would depend whether the patient has positive cultures or negative cultures. Anyone who has positive cultures, we know that we give the antibiotics until the cultures become negative, and for a minimum duration of 10 to 14 days. I think this is all what I have already spoken about. So to summarize, and what are take-home points? Once any cancer patient post chemotherapy lands up in the ER, within 15 minutes of their presentation, they should be assessed, do a thorough clinical examination, look at the possible sites of infection, look at the hidden sites, oral cavity, sinuses, catheter sites, perianal, groin, and after drawing 2 sets of blood cultures from the peripheral and from the central axis device, if available, please administer the first dose of the antibiotic within 1 hour immediately. If the primary consultant is not reachable on the phone, you can, looking at this presentation, I'm sure now you know, based on the patient's previous history, based on the patient's clinical presentation, you can now decide which antibiotic to administer the patient. Risk stratify them. Probably most of them who land up in the emergency would be high-risk patients, and decide whether you want to give an escalation approach or a de-escalation approach as far as antibiotics is concerned. And then this reassessment would happen in the ward. As of now, I think until we develop our own antibiogram, our first-line empirical antibiotics will remain cefepozil, sulbactam, and amikacin for high-risk patients. Patients who have previous MDR sepsis, those who have septic shock, you might as well as directly start carbapenems and add colistin if necessary. Patients who have the risk factors for gram-positive sepsis, add gram-positive cover immediately. And this is the checklist that I use in my patients when managing febrile neutropenia patients, especially those who have hematolymphoid malignancies. And this basically is the same parameters which I have discussed with you all in my presentation. Thank you so much for your patient listening, and I'd be happy to take any questions and comments.
Thank you, sir. It was such a detailed presentation from your side. And the topic is open for discussion. I think we have a first question from Mr. Shiva. Role of markers in escalation, de-escalation, sir.
Yeah, so we have the sepsis markers like CRP and procalcitonin that we routinely use in our practice. I think in escalation versus de-escalation, the role of markers is only secondary. The primary role would be to look at the patient clinically, look at the patient's past history, look at the burden of the symptoms that the patient has, and look at your own antibiogram of your hospital and decide whether to choose an escalation or a de-escalation approach. But once you have started your treatment, then you can monitor your CRP levels serially on a daily basis, which gives you a more quicker estimate of the patient's underlying burden of illness, and decide whether the patient is doing well or not. Procalcitonin, it is a more specific marker of bacterial sepsis, but its role as a repeated testing in the form of deciding your antibiotic policy has never been proven. It has a prognostic role, and it can help you clinch your diagnosis regarding bacterial sepsis, but not so much in choosing your antibiotics and deciding what to do as far as your antibiotic choice is concerned. Okay, I hope that answers the question.
Yes, sir. Sir, is there any role of a colony-stimulating factor in the ER?
So most patients who come up with febrile neutropenia in the ER, they have already developed febrile neutropenia, correct?
Yes.
So once they have developed febrile neutropenia, giving colony-stimulating factor like grafil or pegfilgrastim, that is secondary prophylaxis, that is treating the neutropenia with growth factors, This has not, to my knowledge, in any trial shown any survival benefit. If at all the growth factor has to be given, it has to be given after the chemotherapy, the 1 day after the chemotherapy that we give as a prophylaxis. But established neutropenia being treated with filgrastim in very select situations is when we recommend it. That is when you know that the patient has a profound neutropenia, ANC is less than 100, and based on the patient's clinical profile, you think that the patient will have a prolonged neutropenia more than 7-8 days. And in those situations, on a case-to-case basis, after discussing with the oncologist, you can decide whether to add growth factors. But routinely, no. It is only the correct antibiotic approach which is of utmost importance for reducing the treatment morbidity and mortality.
Okay, sir. Thank you. It was really good interacting with you. If there are no more questions from the audience, I think we can wind up the topic for today.